I'm Jules Plumadore. I'm the community advocate for the Mental Health Association of San Francisco, and I'm also here today speaking from a peer perspective. And I absolutely hear what you're saying. I think a lot of us can be technically doing all the right things and still be feeling stuck. And that's in fact something that I've been dealing with the past few years myself. And one thing that I think is a key component, a missing piece of the puzzle that we often overlook is trauma. And many, if not most of us who identify as peers, as consumers, have underlying trauma. Either that is the underlying trauma is what caused our mental health challenges in the first place, or it comes as a result of the things that we've endured because of our mental health challenges. I think until you really start to address trauma in an individual life, you're going to keep repeating the same patterns over and over again because you don't know a way out of them. You can be doing, like you said, all the right things technically and still not be moving forward, not making progress. And that's one element of peer connection, is identifying with other people who have gone through the same things, being able to talk through that with somebody who's been there and who understands. It can also be extremely helpful to work with a therapist, a professional who specializes in working through trauma. But boy, some of that stuff really needs to be resolved before we can start to envision a future for ourselves. Because I think a lot of us, where we are for a long period in our lives, we don't see a future for ourselves because we've been told we don't have one.
Well, I guess this is a question to the panel, and I'm speaking as a family doctor who owned a minor emergency in another state and saw people from many walks of life, and also was the physician who would initiate psychiatric admissions. And after 20 years of practice, I discovered the vast amount of research onto medical disorders like periodic limb movement disorder and obstructive sleep apnea. And I realized as long as almost all my colleagues had been misdiagnosing people as having psychiatric disorders, when in fact they had physical disorders we had missed. We would recognize their daytime symptoms as a psychiatric condition rather than a physical condition that had gone neglected. I'd like the panel to discuss this because I discovered that Harvard Forensic Psychiatry was actually teaching that people with depression had caused their own sleep apnea. Something that I guarantee you no one board certified in sleep medicine would have agreed with, but was being taught forensically and forensic psychiatry. It was just blew my mind. I'd like y'all to discuss the issue.
Well, let me just say initially that I think all psychiatric disabilities are really biological disabilities. I mean, the biological and genetic component to mental disabilities do make them very similar to physiological disabilities. And I think that's what a lot of people don't think about and discuss enough. We hear the term, oh, it's just all brain chemistry, but upon further reflection, I believe that in a larger sense, they really are the same. That is the physical and the mental disability, because they are based on neurology, on genetics, and they're not really that separate as the medical culture, the DSM, Social Security wants us to see. And I think a belief in the concept that mental disabilities are biological and genetic would also stop so many people from sweeping it under the rug, so to speak, because on a lowest common denominator level, I think they're basically the same. That doesn't address all your concerns, but at least as a starting point, that is my belief.
Stephen, with all due respect, I would like to say that I agree with part of what you're saying. I would also disagree to a certain extent. To the extent that there is a complex interplay between the body and the mind, absolutely, you're correct. And you can't, I think we often want to treat the mind without treating the body, or treat the body without treating the mind. And I don't think it works that way. I think we need to think holistically and take the entire organism, the entire person into account. That said, I think that it's, in some cases, there may be a biological component to some mental illnesses, some mental health challenges, but there are also life experiences that can lead to mental health challenges. And I have to be totally upfront and honest with you. I like Rob here, I come from a recovery perspective. I am pro-recovery, I'm pro-wellness. And so the language that I use, I don't like to use the terms severe mental illness or mental illness. I use mental health challenges because mental health challenges are something that are universal. It's part of the human condition. And that's how I perceive my experience. And so I think that it's also not necessarily accurate to say that approaching mental health challenges as biological and organic reduces stigma. In fact, Dr. Patrick Corrigan, with whom the Mental Health Association of San Francisco works closely, has done extensive research to show that that's not the case. You would hope that approaching mental health challenges as something brain chemistry, biological, would put it in the same category as other physical illnesses that you can test for. Apparently it doesn't. And he's done studies to show that. So I do agree absolutely that, that yes, there's no way to effectively treat the mind without taking the body into account. But I stop far short of saying that mental illness, mental health challenges are always biological. To speak specifically to your question, there are things that have certainly influenced my diagnoses. I have a diagnosis of schizoaffective disorder, for example. The diagnosis of schizoaffective disorder came after I had been homeless and was malnourished, and had a lot of nutritional deficiencies because of that. And yes?
Why wouldn't you want your diagnosis to be encephalopathy due to severe nutritional depletion rather than schizoaffective disorder?
I absolutely would. What I'm talking about
you.
is my experience was that at that time there was no taking into account of the fact that I had been malnourished, that I had nutritional deficiencies. That was not ever taken into account.
So no one considered to re-nourish you to give you the supplements or diet that you needed.
No.
Before
Absolutely not.
assessing a diagnosis you might carry for life.
Absolutely, that's correct.
And I hope you're angry enough about that to keep speaking out.
I am, thanks. Yeah.
I can speak as a psychiatrist about this, that sleep is always something that I ask about. It was taught as one of the four sort of pillars of mental health, is sleep, appetite, energy level, and I'm blanking on the fourth one, but that's just something that should be assessed if somebody is coming in with any kind of psychiatric symptoms. And depending on how thoroughly it's assessed, has a lot to do with how much time there is in a session, or how much, what the available, whether people can get a sleep study, what the funding resource, all of these things play into that. But that sleep is one of the great glues of the mind, and so that should be routinely assessed, I think, in any kind of health forum.
There's no amount of talk therapy with that patient is going to replace the fact that your education did not include the information you needed to understand a nutritional depletion as a cause of behavioral symptoms. I'm thinking about the fact that I discovered years after I trained at Galveston Medical School, University of Texas Medical Branch, where they favored things like shock treatments for patients. They never taught us about the long history of niacin deficiency being found to be a cause of psychiatric hospitalizations, especially in the southern United States. I found that out from a book written by a physician for the lay public. And I'm thinking, why did they leave this out of my education? Well, you can follow the money. You can simply follow the money. But I'm saying that your education is almost certainly depleted of the information you needed to make an appropriate diagnosis of an encephalopathy due to a nutritional depletion. And I would love to hear your perspective on that, but that's been my experience with looking through medical textbooks and looking at the different amounts of information you have. You can look at things like periodic limb movement disorder, which I have met people in a public setting who had behavioral forensic specialty designations at prisons, at San Quentin prison to be exact, who'd never heard of periodic limb movement disorder, which is a prominent sleep disorder that causes such severe depletion of sleep that the person is so irritable they get labeled all kinds of psychiatric. And if you put them on SSRIs, they typically will get worse, much worse, and perhaps even dangerous. And so I know as a psychiatrist, as a fellow physician, you didn't have the information accessible to you easily. Just like me, you would have probably come across it when somebody confronted you with your ignorance, or you found it in the course of reading elsewhere. I'd love to hear your perspective on that.
I respectfully disagree with you. Like I said, I feel like every assessment that I make of an adult or of a child includes a careful assessment of their sleep and their appetite and their nutrition. And if a kid's not eating breakfast, I'm a child psychiatrist, if a kid's not eating breakfast, then that's the first thing that needs to happen, is at least just get something, some yogurt or a banana or something before you go to school. Otherwise, there's no way that you're going to be able to function optimally. And so, in terms of the details of what you're speaking about, you're taught, 1,004 things in medical school. And if this is something that you learned about, we're free to learn about those things. I think it's unfortunate that, you weren't given a nutritional assessment, or that you weren't able to get that piece of things put back in place before you got a terrible diagnosis, So, or a difficult, whatever, diagnosis. That's not something that anybody wants to hear if there's a lot of nutritional things going on. If those other pieces were in place, then I guarantee your symptoms would have been quite different.
Could I address something quickly about that? My name is Veronique, and I am currently at San Francisco State doing my MS in rehabilitation counseling. And what I'm hearing is, lady, the nurse, and the doctors and you guys, we all have specialties, right? We take care of this and we take care of that, oncologist, cancer, psychiatrist, mental health, and so on and so forth. And in my perspective, in my studies, we've been pounded on the head about diversity, about socioeconomics, about race, about ethnicity and sexual orientation and all that. And it seems that we all agree, but we agree in our own specialty, right? It's hard for me to fathom how we can change something where there's no communication among, mental health providers, doctors, nutritionists, and so on and so forth. And I think that's, what can we do, right? How can we communicate? I mean, yes, we get, our education in school, and so hence, maybe you privately read about, if a kid doesn't go to, the school with a, belly full of good nutrition, then, deficiency happens. Excuse me. But it seems to me that we all have our specialties, but yet we don't communicate with one another. And I feel like this is where, the wheel is squeaking. Can you maybe address that? Because I know, doctors, I've heard that, anything that has related to LGBT, I think the entire studies, they get, half an hour on, how to treat a person who is of different sexual orientation. Same thing with disability, same thing with physical and mental disability. There's very little done to it. But yet, instead of becoming an expert in that, there are rehab counselors, there are, physical therapists, but we need to be on the same page. I don't know, it's just a food for thought.
Let me just say this about communication. Communication, and more specifically, effective communication, from a legal point of view, is the basis for eliminating the discrimination in terms of barriers, whether it's to programs, whether it's to employment, whether it's to education or other basic realms. And effective communication means, for example, a lawsuit that I headed against the Social Security Administration, so that people with mental disabilities had the same program access to work reviews by the Social Security Administration's employees. Now, the employees were not trained in anything mental or even medical. They were simply asked to do an analysis with people who had autism or schizophrenia or anxiety and or depression, whether or not there was evidence of cognitive deficits. And what effective communication means is the person who's doing an analysis must have a basic understanding of the mental or developmental disability in order to apply their ordinary concepts, such as, do they have an impairment-related work expense? How would a Social Security claims representative know if someone had an impairment-related work expense if they didn't know what the disability was? Or how would they know they had an independent living skills trainer or job coach? How would someone know if someone had an unsuccessful work attempt, another Social Security Administration term, if they left their work based on schizophrenia, but the employee with schizophrenia didn't tell the employer for fear of word getting around and not getting a job? Yet they require evidence by asking the employer why the person left. Now, this is an area where effective communication between the agency, in this example, it's the Social Security Administration, and I don't mean to just pick on them, it isn't just them. And those people are very nice people, they're just not trained at the level where they do these reviews. But in order to have equal program access, meaningful equal program access, as they call it, they have to understand the nature of the mental or developmental disability and know something about the symptomatology, even to know what questions to ask. So what you're talking about comes to my mind very quickly, having spent years litigating these things, and on the bottom line, it boils down to, in most arenas where there's a barrier or divide with between some people with mental disabilities, is, why isn't there effective communication? What, all they need is training. Why don't they give it? It's because they don't do medical at Social Security. The states, the 50 states, state agencies, DDS, Disability Determination Services, they do medical. And there's where a disconnect is. And I'm sure the same kind of problem is happening in other realms. I happen to be a Social Security practitioner, so I can sit and talk about, disconnects there. But the communication thing you bring up is extremely important in this whole discussion we're having today. Please wait for the microphone, just so we and our...
No, thank you for your comment. But let's talk about how we can do that.
I think it's partly, when it comes to a large federal agency, it's training. They train them on all kinds of things, but nothing as to, in disability programs, the actual disabilities. And I think it's more discourse and discussion, such as the one we're having right now. Unfortunately, this kind of seminar is not routine enough. And that has a lot to do with the stigma too often associated with mental disabilities. I mean, to come and talk about mental disabilities on a Monday afternoon is not the most inviting topic for a lot of people. I mean, who wants to sit down and talk about being crazy? And I use that in the very nicest, most compassionate meaning. And I used it, yes, on purpose, knowing that we're talking about choice of language also in this seminar and discussion. But it seems to me those are two ways. Other people may have more suggestions besides training and discourse, but at least through education and public awareness, it would seem to help bring about more effective communication.
As a psychiatrist as well, I would definitely agree with what you're saying, that communication is key. What we've all been saying, that communication is important amongst multiple specialties. And I think one area of effect of why there's not as much communication between physical therapists, psychiatrists, family, clients, is probably time. I think a lot of what we're talking about here is education and training and having more discourse on information on the recovery model, on changing the language, talking about stigma. But a lot of this is a very self-selecting population. We're coming here because we recognize that it's an issue. And I think a lot of the medical model is of where we are in training and where we are working with multiple specialties is still based on that medical model where people are caught up in and just treating symptoms, not thinking about talking to as many people, not communicating as effectively, and that causes errors, that causes people to not feel comfortable speaking up and ultimately not providing as good of healthcare. So I think having more of these conversations, talking more about how to increase communication, recognizing it as a main cause to drive better healthcare, to decrease medical errors, to increase satisfaction for providers, satisfaction for clients, is just very important. So.
Yeah, just suggest quickly that often the amount of paper that we have to fill out before we see a physician or anyone could include that kind of thing, where you see the person very holistically.
That's true.
So are there, do they have food, housing, support? I mean, just it's a little tiny drop in the ocean, but I think that should be part of it.
I can offer a little drop of support. There's a committee that I sit on that has people from GGRC, the Golden Gate Regional Center, that is a funding stream and treatment avenue for people with disabilities diagnosed before age 18, San Francisco Unified School District, Department of Public Health, and a few other agencies. And what we're really hoping for is to get a blanket consent form for release of information. Because if each one of those entities has to have their own signed piece of paper that's being faxed back and forth, if you just count, let's just say the school district, GGRC, and DPH, you're talking about a good 20 or 30, 40 minutes, potentially, by the time people are getting these things signed, discussing it, faxing it. Now, I'm all about protecting protected health information, but these things are at direct odds if you're talking about coordinating care. Our current privacy laws, which come largely out of stigma, and holding off mental health, substance abuse, and primary care, physical health, all these things we know are deeply related, but when they're separated by so many legal and bureaucratic, every piece of paper you have to get signed is another thing that's going to hold something up. And when these things pile up, as well as we all know, it becomes quite overwhelming. I looked at my clock a second ago, and in the hour and 15 minutes that we've been sitting here, primary care doc would probably have seen about 7 patients, possibly, and completed charting on those 7 patients. And that is just not a lot of time to be addressing the large spectrum of things that we're talking about. So I just want to second Dr. Miglani's statement that time really is not our friend here.
What I'm saying is that earlier I said that I was once told that medical doctors, got trained, but maybe half a day issues like, diversity and, LGBT was one example, but it could be disability. I mean, it's like, it's very pathologizing. It's like, what's wrong with a person?
Mm-hmm.
So the strengths-based approach, or what I like the World Organization, the World Health Organization model,
Mm-hmm.
treats that, as seeing the person as holistically as possible. But if you don't have the time, as you said, because follow the money, right? So maybe in the doctor's education, it should be absolutely included, not just half a day.
How to manage time, or how to
see a person holistically, how to really understand, maybe talk about the medical model, maybe talk about social and minority model and the WHO model and all those models that we talk about.
I think that is certainly starting to be addressed much, much more in medical schools. I mean, we had and this was back in 96 to 2000, a medical practice in the community program where you spend a week working with a primary care doctor, but a large part of the curriculum was going out and finding about organizations like People with Disabilities, and going out and finding what's out there and what's available to be doing just exactly what you're saying. There's a lot of information that you have to learn in medical training and in nursing training and in all of our walks of life. There's a lot to learn. Yeah. So in terms of the proper amounts, these things are always competing against each other. And I think that it's getting better. I think that the public largely has demanded that, because they do want to be seen as a more people-centered, paradoxically at the same time that there's given less and less time to actually do that.